everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. In this episode, I'm delighted to have as our guest Dr. Kris Chrouser. Dr. Chrouser is an associate professor in urology and the S. Matthew Berge Research Professor at the University of Michigan and the VA Ann Arbor healthcare system. Her research aims to maximize surgical outcomes by optimizing surgeon performance, intraoperative teamwork, and surgeon well-being. In addition to teaching operative urology, she also educates trainees in surgical ergonomics, non-technical skills, and improving workplace well-being by utilizing quality improvement techniques. She serves as the site director for the VA Surgery CRQS program and is the high reliability organizational Clinician Champion at the Ann Arbor VA. Hello, Kristen, and welcome to the Surgical Ergonomics podcast.
Thanks so much for having me, Geeta.
Wonderful. So should I switch to calling you Chrouser as I normally do, or would you prefer
Sure.
Kris or Kristen?
Well, anything but Kristen, really.
Okay, all right. Well, there we go. Chrouser it
Kris,
is.
that's fine.
All right. So, Chrouser, please tell our listeners a little bit about yourself, including your training background, and how did you actually become interested in surgical ergonomics?
So I went to medical school in Frigid, Minnesota at the Mayo Clinic, and I stayed there for residency. And then I went overseas for a year and I did a fellowship in international urology, which was really focused on reconstruction. A lot of obstetric fistulas and guys who'd been hit by cars and had terrible urethral strictures. And then I came back and did an MPH at Hopkins. And I got interested in surgical ergonomics actually initially through my research because I had started out studying a lot about surgical complications. And then that led to this interest in kind of the things that cause complications that aren't in the NISQIP database, essentially,
Yes.
like that weren't patient factors, but there were these unmeasured things that I knew from working in the operating room happened. And yet when you read the op note, they weren't in the op note. And so there were just so many things that I realized were sort of playing into kind of some of these outcomes. And especially when you see complications happen sort of in cascade, you like one thing in a case goes wrong and then something else and then something else. And I thought, like, there's a lot of complexity in the operating room, and how that plays together became a real interest of mine. And of course, a lot of that's associated with how we function under stress, which has become kind of long-term focus of research. But in that process, I started to realize that, and at the same time, I'm building my own clinical practice. And I distinctly remember like my first day with no resident, and somebody scheduled 6 flexible ureteroscopies. So the urologist in the audience, like, this is back in the day where they took a lot longer because the lasers weren't as good, and just the hideous positioning for 6 cases in a row. And I remember going home and I couldn't look in my rearview mirror. This is before backup cameras. I couldn't look over my shoulder. And I was like, that surgery really hurts. So it was a combination of my research and then sort of personal experience that I started to think about how our physical, like, we bring our pain into the operating room and then we perform. And so it has to have downstream impact on performance. And so that's kind of this sort of coalescing of kind of those research and personal experience really got me interested in like what are we doing that's so wrong, and why isn't it taught, and how can we fix it has turned out to be a focus of my research in the last few years as well.
I see. Okay, well, I really appreciate you sharing that. And I was thinking, I wonder who Krauser ticked off that day to have a new resident and six ureteroscopy cases of back to back. But, the reality is sometimes that's exactly what we have. I mean, we have to, go with the cards that we are dealt, and some days that's exactly what it is. So, for our listeners, I'm gonna just let them know that I actually first met you, Krauser, because you were part of that core interest group that ultimately became the Society of Surgical Ergonomics. And then I think early on, you and I were on a virtual panel together for the first sort of virtual HFES meeting. I think it was in 2021. And that's when I kind of first heard about what you described here, like bringing our pain, our stress, and there are these other intangible factors that don't seem to be measured. And I remember how you presented this as the surgical stress effects model. So just to kind of go a little bit further about what you described in the last few minutes, could you tell our listeners a little bit about what this model entails and how does it pertain to surgeon pain and procedurist pain and surgical ergonomics?
The SSE model it's centered around stress. And so there's several ways to conceptualize stress, but essentially one of them is this imbalance of work demands and work resources. So for surgeons in the audience, you understand that if you have a really tough case and you have the A team, it's okay, right? If you
Yeah.
have a really tough case and no one knows what they're doing and everyone in the room is a trainee, it can really be hard. And so that balance is what sort of tips us over into being stressed or not. What the model does is that's kind of at the center, but what plays into it is I think where it gets really interesting because you as the surgeon walk into the room, but you also have each of your team members walk into the room, and everybody has their own physical pain, emotional mindset, whatever's going on in your psychology, all of that walks in the room with you. So if you have a fight with your partner before the OR, it's probably a harder day. I mean, there are a lot of things that we don't measure and we might not even know about our colleagues. And so there's that kind of individual, I would call them individual and team factors box that's feeding into the stress. And then you have this organizational factors bucket. And that's things, that are essentially decisions that are made like way above our pay grade about scheduling and how quick your turnovers are and whether your instruments are clean and things like that that are very much at an institutional level. I work in the VA a lot, and so the fact that we have to really start winding things down in the late afternoon is really hard when you've worked at places where you could operate till 7 or 8 and no one cared. But those are the kind of these organizational factors. And then there's this bucket of which I think is very relevant, especially to surgical ergonomics, this bucket of we call environmental and technical factors. So in the operating room, that would be very much like how the equipment's arranged. And some of those things you can control and some of them you can't. I mean, we still have rooms at the university where the monitor for our lab cases is still on a tower. It's not on a boom.
Yep.
It doesn't hang from the ceiling. So it doesn't adjust as much. So some of those are the kind of room setup things, but then there are these actual like the tech. So whether my laser is working, where my laser sits, how loud my laser is, along with the bear hugger and all the other things with fans that are running in the room. And then things like the equipment that we use. So the instruments, which we all know there are certain instruments that are just really not really made well, or at least not made to kind of accommodate the wide variety of surgeon hand size, shape, strength, things like that. So then there's that bucket. And then you have the patient factor bucket, which is difficult anatomy, like a third time re-op, or someone who's just really sick and you're rushing because you're trying to get them off the table. So all four of those sort of buckets sort of feed into that job demands, job resources balance. Out of that comes stress, what I call stress or challenge. So if it's challenge, you've got more resources than you have demands. Like it might be a tough case, but you have everything you need and your team's great and you can get the job done and you feel really good at the end of the day. Or the job demands exceed the resources, and that's where you have stress. And then stress comes out in multiple ways. So stress can be that you get snippy with your team. So that's kind of that psychological overflow. There are physiologic signs of stress. Anybody who's had like an intra-op complication suddenly start to get a little shaky and your heart's racing and you're trying to catch your breath. And as you
Yep.
plug the hole that's bleeding and try and calm yourself and everyone else down, like there's a physiologic response. And then you have the sort of behavioral, well, we mentioned behavioral, but the emotional response, which
Yeah. Yeah.
flow over into your behavior. So kind of this mix of stress response. Now, a lot of people hold their stress in their neck.
Yes.
So
Most common sight of
after,
complaints of pain among operating room personnel and procedural personnel. Yeah.
right. So now you've got, you might have come in with neck pain from the case last week and you had, a tough, your setup around you, like we talked about, the environment isn't ideal, but now you have run into something in the case that's got you stressed, and then you have that on top of it. So, and then the model's literally designed to kind of reinforce the idea that there's these downstream effects. So once you have your stress and your response to the stress, then you have an impact on your own performance and you have an impact on your team's performance, because if you mouth off at your team, they're like licking their wounds in the corner and not really engaged anymore.
Right.
And then all of this can decrease your surgical efficiency. And then the downstream concern is the patient outcome.
Right.
So I think honestly, the reason I developed the model was to show that there's a connection between something that
Mm-hmm.
doesn't seem related, like the schedule and how short the turnovers are, or this instrument that doesn't fit my hand, and
Right.
patient outcomes. And granted, that's theoretical at this point, but
Mm-hmm.
each piece of that chain, there's evidence, not always in surgery, but there's evidence outside surgery. For
Right.
example, that when you're stressed, you don't perform as well on certain types of tasks. You don't think as straight. I really like the model because I keep coming back to it in different contexts. Like it
Yeah.
was designed for an acute like setting that,
I see.
a day in the life kind of thing. But if you take it into like the chronic setting, the outcome is, burnout. All these things,
Right.
chronic stress leads to burnout. And so I think that, the inputs are similar. And when we start thinking about long-term impact on surgeons, we have to remember that those same inputs, over a career can lead to career-ending injury from an ergonomic
Right. Right.
standpoint, or just burnout from too much stress. So yeah, it's been something I've been chipping away at over my career.
No, I know that you have, and I appreciate that you have. And I actually have to tell, I don't know if you know this, but I'll let you know as well as our listeners know. I actually reference your model and you in every talk that I give. I talk about the surgical stress model as it relates to physical ergonomics and how, as you pointed out, pain probably, and I reference it just for the kind of MSK symptoms, not kind of all the things that you mentioned. Pain is probably not as likely to affect our sort of technical performance, right? Because that's a lot of muscle memory. But it's these non-technical skills that you mentioned, our heart rate going up, our being snippy with the team, poor communication, situational awareness, all these things that then we know in other contexts affect quality and safety outcomes, right? When it comes to patients. So I really, thank you for putting that model together and for explaining things. And I will share one more thing with our listeners that, Chrouser's model, I just realized that Chrouser, you're working at the intersection of the various kinds of ergonomics. So in our first episode with Sue Hallbeck, we actually talked about the definition of ergonomics being the interaction of humans with other elements of a system. And there's physical ergonomics, which we're all kind of talking about, surgeon symptoms, pain, etc. And then you brought in cognitive ergonomics, right? Each of the people coming into the OR are coming with the whole set of things. They're bringing their entire self to the OR. It's not just, them as a scrub tech or you as a surgeon. And then the third piece is the organizational ergonomics, which you also reference, things that we have no control over, but the decisions here can then affect, downstream outcomes. So very fascinating, and I'm hoping that you're going to continue to work in this area. Now, you said a couple of times, you said, this is theoretical and I used it for this kind of explanation and I keep coming back to it. So let me ask you, why is it that, or actually, let's take a step back. Is there actually now, since you developed the model, data to show how poor ergonomics, and I mean physical ergonomics or cognitive ergonomics, can affect patient outcomes? Do we have the data? And if we don't, why not?
We don't have quantitative data at
Okay.
all. There's some qualitative data. Some of it, shame on me, I just haven't gotten around to publishing yet because qualitative research is so time consuming
And
to
it's hard to
analyze.
publish. Yeah.
It's hard to publish because, yeah, I actually have to say that in the last 5 years, I've seen more, which
Hmm.
is for those of us who use mixed methods, I think is heartening. But
Yeah.
for a long time, people were like, oh no, you can't publish that in a surgery journal. So unfortunately, that's changing. So I have some qualitative data, and I have collected some that's published, but it was in medical students. So I mean, I think what I really need to do is get the surgeon studies out there.
Hmm.
But the idea is that, and one of the studies I did, actually, we interviewed the entire team. And
Hmm.
I actually think that's helpful because sometimes even in a qualitative study, someone might say, oh, well, I was so angry that I was shaking and I'm sure it impacted my performance. And then like on the outside, the team didn't recognize that. And
Right.
more commonly, oh yeah, he was so mad and he was stomping around. I could tell he was furious and, he was snipping at the resident and you get this and the surgeon was like, I was fine. So, so there's often a mismatch, but I do feel like that we have some evidence that's either an outsider looking on and
Hmm.
seeing a degradation in performance, mostly, like you said earlier, non-technical performance. So this is
Hmm.
poor communication. This is like getting that tunnel vision where people are not, situationally aware. The communication in the patient safety literature is the worst thing that can happen in a
Hmm.
case. Like that's I think when we start to see these cascades of complications,
Yeah,
it's
it's the root cause is breakdown in communication, right?
oftentimes
Yeah.
is, yeah.
Yeah.
I will say that in interviewing and I've been honestly a little surprised at how honest people were willing to be because I didn't think they would be. People
I
who are
see.
willing to say, yeah, I've done cases where, when things started to go wrong, like my technical performance just, went down the
Hmm.
toilet. And I think that, that's really brave to say. I think
Yeah.
most of us, if we're really honest, would admit that's probably true. For those of us who do really, really routine cases where there's a ton of muscle memory, I think, like you mentioned earlier, there's some
Hmm.
protection there.
Hmm.
I
Hmm.
think things like intraoperative decision making, like whether you do something or not, is probably more impacted than the actual, were you able to sew this up? And so, but again, like when you look at technical errors, they're often errors of judgment. If you look at if you look at series of for like
Hmm.
adverse events or bad outcomes. So I do think there's evidence it's just weak. Why we don't have quantitative evidence, I would suspect that the system's not designed to collect it. So it's never going to be passively collected, partly probably for medical legal reasons. But I would say that even in a situation where you design a study where you try and collect that prospectively, because
Hmm.
adverse events are so rare and
Yeah.
because there's probably a lot of different ways you can get away with doing something, even if you don't do it perfectly. The human body is amazing in its ability, in my opinion, to heal, even if
Yep, I would agree.
you
Yeah.
don't do it perfectly. That is just technically difficult to study. Like the sample sizes would have to be massive. And so
Right.
and I don't think there's like money and political will to make that happen. But I do think that, trying to conceptualize the whole process in a way where people can see that there's an impact on the patient is, a baby step in the direction. And we don't necessarily have to use only data from surgery to make our arguments, because
Right.
other fields I think have been more proactive about, collecting that quant data.
Yeah, I remember, I mean, I know you just said, this data is not kind of available, so we don't have the quantitative studies, but I think we as a profession also are a little bit to blame, right? Like if you go on probably labor, websites, etc., you can find rates of disability and injury, etc., for various professions. I don't think you can find the same data for physicians, surgeons, proceduralists, because we are so, that surgical culture is so ingrained that we will keep working until kind of, there's no other option.
Till we
And
fall over.
yes, till we fall over. And if you listen to the podcast episodes so far, I mean, every episode there's at least somebody who says that, I couldn't feel my arm, but I had 4 cases, so I had to go do it.
Yep.
And in general, for various reasons, we are not going to report that data. So I think the numbers just aren't out there to be able to even indirectly draw those correlations for outcomes, correct?
That's true. I think that a part of it's surgical culture
Yeah,
where we literally just push through the pain because that was kind of billed out to us as part of
yeah,
the job.
yeah, yeah.
Um, and I think part of it is the structure of a lot of hospitals and what's classically been, in outside of academia, that surgeons were self-employed or employed not by a hospital. That's changing, obviously.
Right, right.
But historically, that means that, you wouldn't necessarily, the culture isn't that you would ever report an injury to your hospital because that's just the place you do your surgery.
Correct.
And so people would have disability insurance that would be separate from their work. And so
Hmm,
there's
hmm.
not that stream of reporting that would go like to the government or where anyone would be collecting it. And so I think that's a big piece of it. But I also think that a lot of these injuries, like musculoskeletal injuries, are chronic. And so and a lot of people do things outside the operating room too, and so it's sometimes unclear, is it this surgery that I'm doing over and over that's the problem, or is it because I'm aging, or is it because I did too much rock climbing, or
Yeah.
I feel like because they're kind of long-term cumulative injury type things
Right.
that also clouds the issue. I mean, I have a friend who had a very clear nerve injury during a case, like
Hmm.
along like flat reconstruction. You know, even for her, it was sort of difficult because at the time she didn't report, and then she went back and tried to report, and then there was all this pushback. And so, I think who knows if that would have ever gotten reported to the government. So I think that there are a lot of reasons why reporting rates are low. I recently have done some work with Andrew Gabrielson looking at some
Yes.
data that's available from like government-based data
Hmm.
that's been kind of recently made available that's more granular than we've had in the past. And that sort of shows that the the rates vary by role within healthcare workers, and that, like
Nice.
nursing rates of reporting are much higher than physician rates of reporting for it, which makes no sense because like a lot of times, especially in the OR, we're doing very similar things. We're both moving patients. We're both
Hmm, hmm,
so
hmm,
I do think that culture really does play into it a lot.
hmm.
I'm wondering as people become more hospital employed, whether or not those reporting patterns will change. But
I
right
see.
now, it like looks on paper like we don't have much going on. But when you do a survey, even a survey that's not got response bias in it, for example, the my specialty, the American Urologic Association, does an annual census, which asks a lot of questions. And one year they put ergonomics questions on it. And
Uh-huh.
like 40% of urologists have pain. And so it's probably the best real estimate you have because
I see.
most of the time people fill out a survey. If they're interested in the topic, they'll fill out the survey. So they're more
Correct.
likely to have problems with ergonomics or pain, they'll fill out a survey. So you
Right, right.
overestimate.
Yeah,
But this is a sort of a generic, like there was no ergonomics on the label at all. It's just a few questions they threw in.
yeah.
So we know the prevalence is there.
Hmm.
So, but where are those 40% of 40% of urologists when we look at this national data? There's a big disconnect there.
There's a
It'll
big
be
disconnect.
interesting.
Yeah. Well, hopefully over time we'll start to see, as we keep getting the word out and why it's important to kind of keep track of things, hopefully this will change. Now, you did bring up the AUA, and I know you've given a number of talks, not just at the AUA, but at other meetings about best practices for urologists. Now, Andrew Gabrielson, who you referenced, was a podcast guest a few episodes ago, and I asked him for some specific tips for urologists, and he actually talked about cystoscopy. But since we have you here today, I'm going to pick your brain about perhaps the urologist, maybe, some of those 40% that responded to the AUA survey might be listening, and the residents and fellows who are listening. What are the best practices when it pertains to urologic practice, whether it's, open, laparoscopic, robotic? What is it that you try to impart to your trainees and the things that they should pay attention to? If you could share those with our listeners, I'm sure they'd appreciate it.
Well, I would say big picture as a specialty, like we're really blessed in urology because we use a lot of different modalities. Like
Right,
I
right.
do, I do microscope work. I do what we call endourologic, which is like to a general surgeon, like endoscopic. We do open, we do laparoscopic, we do robotic. And so in some sense, like we're sort of in the sweet spot, especially if you're a generalist, because you can have an OR day where you do a lot of different things. And I think that's very protective. Now, I do have colleagues in the academic world who literally do the same case every day. When you do the same case every day, you have the same set of stresses physiologically and musculoskeletal stresses. So, but for generalists in my specialty, I think we're really gifted. It's just luck of the draw that we do a lot things a lot of different ways. And so changing it up and if you have the control, like this doesn't apply to residents, but for those attendings who have control over their cases, to mix it up is actually like really helpful.
Good point. Thank you for stating that. Yes, good
I
point.
think also, there are cases that we get used to doing a certain way, like either sitting or standing, and that's another way to mix it up. So maybe you do have a long day of ureteroscopies, but you can sit for some and stand for others. I think being just very mindful of like trying to connect what you do to something that you do in your case anyway. So for instance, like at the end of my time out, I do a little bit of an occupational timeout, so to speak. And we talk about
ergonomics timeout as we're coming, talking about
so
it in the society. Yeah, yeah.
it includes ergonomics, but like for what I do, I use a lot of fluoros. So we just make sure everybody has lead on. We make sure the machine is collimated, and then we adjust the table height, we adjust the screen height. So those are the ergonomic pieces of it. So essentially to sort of optimize the environment before you kind of get
Jump
into
in.
itself.
Yeah.
But I find that's very helpful to do at the same point in the case every time, so it becomes a habit. Otherwise, I think it's really too easy to forget.
So these are some general, tips that definitely our listeners, and it doesn't matter which specialty you're in, right? So mixing things up and then taking the time to do an occupational or ergonomics timeout before you do your incision. What about some specific things that apply to urologists?
I think, well, I do a lot of microscope work and I can do some really long cases. And although, the more modern microscopes have got extra gadgets on them to like improve sort of your ergonomic positioning, just being static or still for a long time is terrible for my neck. One of the reasons that I got interested in implementation of urologic interventions was that I was having so much neck pain after my long microscope cases that it would take like at least 2 massages before I would feel like pain-free enough to go do another one. So I had to space them out.
I see.
And so I started doing the intra-op micro break stretches, and that revolutionized my microscope experience. I quit dreading those cases. I could do like I couldn't do one a day and then one back to back. That was still too much, but I could just have one day in between and do another case instead of needing like 2 weeks. And just stopping, stretching, it also is a good mental break. Sometimes you're just so focused, but I found that break is really helpful. I don't do huge cystectomies and like big cancer cases anymore because I'm in an academic institution where everyone kind of has their own like slice of the pie.
Yeah.
And I do mostly reconstruction now, but I do colleagues that find that really helpful in those long open cases. And then I would say the other thing about urology is, we do a lot of our cases will use loops for, and it's even more common in pediatric urology, but having multiple sets of loops with different focal lengths on them is more important than people think. Because if you're doing an RPL&D and you're deep in the back of the belly, the distance between your eyes and what you're looking at is very, very different than
Yeah,
if you're setting up a vasovasostomy in the pre-microscopes. I use loops before I bring the microscope in.
right,
That's
right,
that's a very different distance than just getting like looking down at the vase. And so you either need to not use loops for one of them more, or you actually need to make sure that the focal distance is appropriate to what you're looking at. Otherwise, your neck is going to tip forward. And the
right.
further your neck goes forward, as we all know, the more weight it has to hold and the more strain on your cervical muscles.
Hmm.
Neck pain is probably the biggest killer of surgical careers that I know of. So
I would agree. Yeah.
that would be one thing I'd suggest. The other thing that I worked with a colleague on here was here at Michigan in ophthalmology was looking at as we become presbyopic
Yep.
and everything, our focal where things focus is different.
Hmm.
We likely need more than one pair of
Pair
glasses.
of glasses. Yep. Yep.
So understanding that early in your career, that when it starts to happen, it isn't a surprise, I think would have been helpful for me because I would throw my head back. The screen is probably already too high, especially using a fluoro bed. There's not a way really to get it down to the
Yeah.
ideal like eye at the top of the screen. And so then I'd throw my head back so I could see through the bottom of my new bifocals. And my neck pain got worse. And then I thought, oh, well, it's just because I'm getting older. No, it's because I needed another pair of glasses that was made for the operating room. So that, essentially take out the distance vision. And they're just very similar to computer glasses. So little things like that, especially for those of us in urology and other fields where we use screens, I think
Hmm.
is something to think about as you start needing those things as the years
Yeah.
go by.
No, all good things that you mentioned. And for our listeners, I'll just, we've talked about sort of or taking breaks and stretching before, and you can, take them in natural breaks in the case, or you can use the app. We've mentioned this before, the OR Stretch app, and I'll include the link again in Krauser, your show notes for this episode. And episode 6 is the one where we kind of talked in detail about how presbyopia affects us all, but you've also clarified that some more, so I appreciate you doing that. In the little bit of time we have left, I do want to pick your brain a little bit about implementation science, right? Because I know I've struggled because I don't particularly take OR stretch breaks with kind of involving the entire team. I will take breaks when one side of the thyroid is out, and then before I go to the other side, or before I start kind of the neck dissection part, so natural breaks in the case. And because I've already had injuries, there are certain specific stretches that I do that are important for my injuries. And if other people want to join in, that's great. But if they don't want to, I don't make it kind of part of the whole OR. Now, I know you've looked at actually how to implement these things in the OR. And I was wondering if you could share some of your wisdom with people looking to implement these things in their ORs. What works, what doesn't, what are some of the challenges and barriers, and what are some strategies to overcome these things? And would you be open to people contacting you if they're trying to implement these things in their ORs?
Absolutely open to being contacted. I will just start out by saying it's way harder than it seems like it should be.
Right.
And we know that because my friend Sue Hallbeck works at Mayo, where they did one of the studies that showed that it worked. And like almost 90% of surgeons were like, oh yeah, I'm going to do this in my OR. And then she went down to the OR to do a different study like
Uh-huh, uh-huh,
weeks
uh-huh.
later. And they're like, oh yeah, you're the stretch lady. I need to be doing my stretches. And they had totally forgotten, like they were
Gotten.
in the study. So to
So
me,
now I don't feel so bad.
right,
Okay, thanks.
exactly.
Well, this is the advantage of having you had trained at Mayo, so you were probably part of those studies too.
Actually, they happened after I left.
After,
I would
okay.
have loved it, but
Okay.
yeah, if I had
It's
known,
hard to implement at the center that gave birth to OR Stretch.
well, it's kind of crazy, but to me, it just underlines how hard it is.
Yes, yes.
And so it's not really difficult when you have a researcher in your operating room to remind you. And
Mm-hmm.
so I think what happens then is the question becomes, well, how if people are open to it, and you have to first assess that, how do you remind them? in a
Yeah.
way that
Yeah.
is, going to happen reliably. What we ended up doing was I felt like we needed to do a baseline survey just because doing something without proving there was a problem didn't quite feel right, even though I knew from the existing national data that of course we would have a problem. The one thing that we did a little differently, which I'm so thankful for now, is we studied the whole team and we surveyed the whole team. So we essentially asked everybody about their pain. So every single role in the operating room. And that was really interesting because it turned out that like the scrubs, like whether they're scrub nurses or surgical technicians or surgical technologists, they have the worst pain of any, worse than the surgeon.
Wow.
So I think getting this sense of like, okay, this is how bad it is, and then sharing that across departments and across roles was helpful because I think people start to realize like, oh, like my favorite scrub nurse so and so has back pain, and like she's part of the A team, and I don't want her to quit. So it can help motivate us when we
Right.
realize that like everyone has a horse in this race, so to speak. So we started with that survey and then we did, and this was a real research project, so I'm not saying that everyone has to do it like this, but we did a real implementation science drive, like pilot essentially. And so you do pre-implementation interviews, formative interviews while the implementation is being implemented, and you fiddle with the implementation while you're getting this feedback from people.
I see.
It feels kind of like QI in there, like you're doing rapid cycle.
PDSA cycle after
Yes,
PDSA cycle.
exactly.
Okay.
And then once you kind of settle on what seems to work the best, then you do post-implementation interviews and you get feedback. And at that time, it was a pilot, we got feedback for what people thought would work best for like a larger rollout. And honestly, like the best feedback I got was in the pre-implementation interviews, the non-surgeon roles were just sort of floored that I was even talking to them. They're like, wow, you're like asking us? Nobody ever asks us. They just come in and tell us what to do. And so from the very beginning, I got a lot of buy-in from the OR staff because they felt listened to, I think, and that their perspective was appreciated. And they also gave phenomenal feedback and they had great ideas along the way. So that part was a little bit of a surprise to me, but like I would say if you're going to pick pieces of this process out as somebody who wants to do it at your hospital, please talk to your staff.
Got
Not
it.
the other surgeons, talk to your staff. Get buy-in from your staff.
Yeah.
Ask your staff what will work and won't work in your context. And then, a lot of the questions you ask in an implementation project have to do with barriers and facilitators to whatever implementation is or whatever you're trying to implement. And so I would say, things that people talked about as barriers, because we did our implementation was kind of a bucket of two things. One was ergonomics training. So you need to know what you ought to be doing. And as a part of that training was the importance of micro breaks, but that wasn't all of it. So most of it was other stuff, like things we've talked about already on this podcast. And then the implementation of the breaks. So we asked them about barriers and facilitators for both. And I thought, it's really true when you think about you can educate a surgical department, that's easy, you go to grand rounds. It's very much more challenging to educate when there's shifts of surgical staff. So they don't all go to the same meetings. They don't all have access to the same Thursday morning educational meeting, but it's only attended by the day staff and then the night people and the overnight shift and like all those people are missing. So you have to think through like, how am I going to get this word out to people who might not be there at 7 a.m. And then, there's a lot of turnover, especially at that time. And there were a lot of people who would be like floating from other departments. And so how do you get those people on board quickly? So the devil's in the details when it comes to some of this stuff. The barriers to the stretches themselves, I think, were things like people didn't realize that they would be helpful. They talked about like the fact that they were get in the zone in a surgery and just forget to do them. And I would say one of the interesting barriers that the staff talked about, but the surgeons did not, was like a lack of psychological safety. And I don't want to get too jargony, but like that sense of not being willing to speak up because you're afraid someone's going to bite your head off, essentially. And so the staff were like, well, Dr. So-and-so's cranky in the morning. Like, I'm not reminding him to stretch. And so, and the surgeons, on the other hand, were like, oh, we're in the transplant section. Our teams interrupt us all the time because there's all this stuff that has to be done during a transplant. So they're always interrupting us. They're totally cool with it. Don't worry about it. We're nice to them. And yet we go talk to the staff and they'd be like, the story was different. So I think, again, it's really important to kind of keep that communication open to figure out like exactly what's going to cause you not to get this to roll out well. I think that the facilitators that we found were close-knit teams. So we did a pilot in HPB, like a liver surgery and transplant surgery. So it was really high acuity patients. And pretty consistent team
staff.
Totally, but enough consistency that like it made the intervention like we weren't starting over every single day.
Right.
And so I think that was helpful. I was really interested to see how much, even some of these kind of prickly surgeons, how much they cared about their staff. And even the staff realized it. They were like, oh yeah, so-and-so doesn't care about his own back, but like he'll bend over backwards for his scrub tech. So, who would have thought? I honestly, and then the other thing that I thought was interesting was, sometimes you have to figure out for an individual surgeon, like what's the best way to their, like what's
motivator.
And so there were some surgeons that were just fearful because they had seen the backstory of this is that there were several serious injuries within this department. And so people were kind of like, oh, that might happen to me. And I think there was some fear there. So some people, it's just sort of self-interest, but there were some surgeons who literally were very much motivated by this idea that I pitched it as this should be the standard. We are going to teach residents to have long, fruitful careers and not kill themselves. This is what we need to be teaching. And so some people's self-esteem, I think, was wrapped up in their role as a surgical educator, and that was sort of the way to their heart, so to speak. So I was very fascinated to find that there wasn't a one size fits all in terms of how to convince people to even try it.
This is all very, fascinating, number one, but two, also absolute gold, right? For those of our listeners who are looking to implement things, various interventions in the OR. So I'm going to include your contact information in the show notes, your social media profile. Do you have a LinkedIn profile?
Not LinkedIn.
Okay, but your email, people can reach out to you by email?
Yeah, email's fine.
Okay, all right. So I will do that. This is just, as I said, absolute gold for people who are looking to implement things in the OR. I just looked at the time. I think when we're chatting like this, Kristen, Chrouser, we could talk for hours, but I just realized we've passed the time we set aside for the podcast. And so I want to take this moment here just to express my heartfelt thanks again for your time and knowledge and being so generous with sharing it with us today. So thank you.
Thank you. It's been fun.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.